Hello.
Yeah. Good afternoon, dear colleagues, ladies and gentlemen. Welcome to today's webinar organized by Asian Pacific Society Cloud Forum of Cardiovascular Disease Series. It is my pleasure to introduce chair of today's webinar, Professor Chung-Lieh from Department of Internal Medicine, McKay Memorial Hospital College from Taiwan. As a co-chair, my name is Dr. Mungunchimeg Dagva. I'm a head of National Cardiovascular Center in Mongolia. As you can see, the topics are extremely important, yet less discussed and thus challenging in our daily practice. Thus, I would like to invite Professor Chisato Izumi, who is the Director of Cardiovascular Medicine, National Cerebral and Cardiovascular Center, Osaka in Japan. And before that, I would like to go through quickly. Would you like to share the preface? And okay, next, please. The regulations of, yes, please, go ahead. In the last slide, please. Oh, no. Okay, just to remind you, disclaimer, the content of this webinar is copyrighted by APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in this webinar are those of the faculty members and do not necessarily represent those of the APSC. And housekeeping, the live streaming content of the webinar will be made available via APSC Cloud and APSC Facebook and YouTube page. Thank you very much. Professor Chisato Izumi, please.
Yes, thank you, chairpersons, and good afternoon, everyone. I am Dr. Izumi from National Cerebral and Cardiovascular Center in Japan. It's a great honor to have been given this opportunity to speak at APSC Cloud Webinar Program. So I will share my slide. Can you see my slides?
Yes.
Okay. So today, I would like to talk about how we should determine the timing and candidate of AVR for severe AS, valve fracture versus extravalvular cardiac damage. I have no disclosure. With increasing the elderly population, the number of patients with AS and undergoing AVR is increasing. ACC/AHA guidelines on the left side and the guidelines in our country on the right side show the indication of AVR, including both surgical AVR TAVR and transcatheter AVR TAVR. Although there are small differences in the details, these guidelines show basically similar content. This slide shows the summary of current indication of AVR for severe AS. So, sorry. So, symptomatic severe AS and asymptomatic severe AS with LV dysfunction defined by ejection fraction less than 50% is class 1 recommendation for AVR. And asymptomatic patients with very severe AS, abnormal exercise test, and rapid progression are class 2A recommendation. And these contents have been determined by previous evidence from many observational studies. Rosenheck et al. Reported a prospective study showing that the cardiac sudden death occurs in less than 1% of asymptomatic severe AS by watchful waiting strategy. There are several studies limited to very severe AS. This prospective study showed that event rate was high in very severe AS despite asymptomatic, and early surgery group showed better prognosis than conventional treatment group. Based on these studies, asymptomatic very severe AS is class 2A recommendation for LVR, even when LV function is preserved. Among these indications, a parameter of extravalvular cardiac function is only decreased ejection fraction. Let me show here the indication of mitral valve surgery for severe degenerative MR. In asymptomatic severe MR, operative indications is mainly determined by parameters of cardiac function. I would reconfirm the natural history of severe AS. Severe AS is pressure overload to the LV. Pressure overload induces LV hypertrophy, resulting in LV diastolic dysfunction despite preserved ejection fraction. When pressure overload continues, reversible myocardial dysfunction due to afterload mismatch develops. At this stage, LV ejection fraction will improve after AVR. With further advances, myocardial dysfunction becomes irreversible. However, patients with severe AS has been asymptomatic for a long time. LV is a direct target of pressure overload by severe AS, but LV damage may induce left atrial dilatation, mitral regurgitation, and pulmonary hypertension, eventually RV dysfunction. From this concept, new staging of AS is proposed in 2017, focusing on the extravalvular cardiac damage. Stage 0 is no cardiac damage detected. Stage 1 is LV damage, defined by the presence of LV hypertrophy, severe LV diastolic dysfunction, or LV ejection fraction less than 50%. Stage 2 is LA or mitral valve damage, defined by the enlarged left atrium, presence of atrial fibrillation, or moderate to severe MR. Stage 3 is pulmonary vasculature or tricuspid valve damage, defined by the presence of pulmonary hypertension or moderate to severe tricuspid regurgitation. And stage 4 is moderate to severe RV dysfunction. The relationship between this new staging and prognosis were investigated using the database of Partner 2 trial. Therefore, study population was symptomatic severe AS with intermediate surgical risk. As the stage progressed, the incidence of all-cause death and cardiac death after AVR increased. This staging classification by cardiac damage has been validated by other studies regarding symptomatic severe AS. This slide shows a validation study from 1,189 patients with symptomatic severe AS, including 77 patients undergoing AVR. They also showed mortality rate increased with advanced of the stage. So now, can this new staging be used in asymptomatic moderate to severe AS? The study shown on this slide proposed a modified classification adapted to asymptomatic moderate to severe AS. They raised the cutoff value of ejection fraction in stage 1 from 50% to 60% and included LV longitudinal strain for early detection of LV dysfunction. In addition, they added stroke volume index less than 30 millimeter per square meter in criteria for stage 4. Study population was 735 patients with moderate to severe AS. Primary endpoint was all-cause death, regardless of whether patients underwent AVR. They showed that mortality rate increased with the advance of modified stage of cardiac damage, even in asymptomatic moderate to severe AS patients. However, I am skeptical about that we apply this staging classification to patients with asymptomatic moderate to severe AS for determining surgical timing. Are there any direct association between moderate AS and cardiac damage? Can low stroke volume be induced by moderate AS itself, or is it due to myocardial disease regardless of the presence of AS? Do we experience asymptomatic patient at stage 3 or 4? This staging system was originally derived from the data of asymptomatic patients at intermediate surgical risk. Direct causal rule is unknown between the presence of AS and cardiac damage. Higher stage could reflect the effect of cumulative cardiac and non-cardiac comorbid factors. We should be careful about that. All-cause mortality is high does not always mean early AVR improves prognosis. So I do not think that this staging can be used as a guidance of the timing of AVR for asymptomatic patients with severe AS at this time. However, is LV ejection fraction less than 50% enough in evaluating cardiac damage to determine the optimal timing of AVR for better outcome, postoperative outcome? So the answer may be no. I think that early detection of cardiac damage and risk stratification of asymptomatic severe AS is important for better outcome after AVR. We should detect earlier stage of LV dysfunction, LV diastolic dysfunction, left atrial dysfunction, and cardiac structure abnormality. LV global longitudinal strain, GLS, the parameters of cardiac MRI, and biomarkers, as well as reconsidering the cutoff value of LV ejection fraction may become better parameters to determine the optimal timing of AVR for asymptomatic patients. Let me show here about some of these parameters. This slide shows a study about LV GLS measured by 2D spectral tracking echocardiography. Better outcomes was shown in patients with beta GLS, and cutoff value was around 15%. This is study from Japan. Severe AS with preserved ejection fraction was classified by pressure gradient and flow state. Prognosis of patients with low flow, low gradient severe AS with preserved ejection fraction could be stratified by GLS. Patients with impaired GLS had higher LV mass index and higher EA over E prime. This slide shows progression of cardiac structural abnormality in patients with severe AS. First, myocardial hypertrophy develops with increased afterload. Supply-demand ischemia, mechanical stress, and increase of extracellular matrix induce diffuse fibrosis, which is a reversible stage of fibrosis. With further progress, myocardial cell death occurs, resulting in replacement fibrosis, which is an irreversible stage of fibrosis. After further progression, cardiac damage is advanced and heart failure develops. Early stage of fibrosis can be detected by T1, native T1 and increased ECV, and advanced fibrosis can be detected by late gadolinium enhancement, LGE, of cardiac MRI. In patients undergoing AVR for severe AS, prognosis was worse in patients with LGE by cardiac MRI. A study shown on right side demonstrated that prognosis in patients with AS became worse with progression of stage of fibrosis. Biomarkers are also useful parameters for risk stratification. BNP, troponin, and other biomarkers have been reported to be useful for predicting prognosis of asymptomatic patients with AS. As I have shown above, these parameters may be useful to detect earlier stage of cardiac damage, but any of them need more evidence to establish the usefulness in determining the optimal timing of AVR. Disadvantage of early AVR for asymptomatic severe AS is prosthetic valve dysfunction. The most critical difference between AS and MR is that the most of patients with MR can be treated with repair. We should plan the schedule of intervention considering patients' clinical course on a lifetime basis. This slide shows my opinion in determining optimal timing of AVR. First, accurate evaluation of AS severity. It is the most important. I want to emphasize this point. If AS is not severe, the relation between the presence of AS and cardiac damage is questionable. If AS is estimated as severe but asymptomatic and preserved ejection fraction, we should try to detect cardiac damage at an early phase. If early phase cardiac damage is detected, we should consider early AVR or careful follow-up with respect to each patient. Tailor-made treatment is important. Early stage of LV dysfunction and LA left atrial dysfunction could be class 2 recommendation, but it remains controversial. AVR is not indicated to patients with moderate AS itself. And now some randomized clinical trial regarding controversial topics are ongoing. Guidelines for management of AS may change if new evidence is established. So in summary, accurate evaluation of AS severity is the most important. Risk stratification is important for improving prognosis of asymptomatic severe AS. However, we should be careful in interpreting the study results because all-cause mortality is high does not always mean early AVR improves prognosis. Early detection of LV and LA damage could become an indication for early AVR, but more evidence is needed. If early phase cardiac damage is detected, we should perform tailor-made strategy, early AVR or careful follow-up, considering patient's clinical course on a lifetime basis. Thank you very much for your attention.
Thank you very much, Professor Chisato Izumi. It's
Thank you very much.
You have brilliantly, so well introduced about the challenging scenario of the severe aortic stenosis. And for the participants, I encourage to ask chats in the chat box, either or in Q&A section. Do we have questions from audience or from a panelist? Most welcome. Meanwhile, I would like to ask Professor Chisato Izumi that yes. In clinical scenario, often we see the patient with combined valvular disease. What do you think, what will be the strategy in this case you advise?
Yeah, combined valvular heart disease, right?
Yes.
Yes, it is very difficult. There's no guidelines, definite guidelines for the patients with combined valvular heart disease. So for example, aortic regurgitation and aortic valve stenosis is the most best parameter is the peak velocity of transaortic valve. So it depends on the kinds of the combined valvular heart disease.
Yes. If let's say mitral stenosis or mitral
yes.
regurgitation, then
we often see the degenerative mitral stenosis, so with annular calcification and aortic stenosis. So it's a very controversial topics. And if the mitral stenosis is moderate or mild, so we treat the patient, we treat only the atrial stenosis. Mm-hmm. But it depends on the risk of the surgery or depends on the patient's clinical background.
Okay, thank you very much. And so, as I understood, the moderate, lately, quite a number of literature were reviewing that moderate aortic stenosis is correlates with also with quite higher mortality, right? Mm. Moderate asymptomatic aortic stenosis. Yes. So in this case, you recommend that we will check the myocardium fibrosis first and to further on stratify on the.
Yeah, basically at present, I don't think moderate AS is indication for AVR. but sometimes it's difficult to separate myocardial factor and valve factor. So it's very, do you think the moderate AS should be indication for AVR if the patient has the symptoms or heart failure?
Yeah, well, if patients are asymptomatic, but with a moderate AS, but if the number of the studies showing that there might be still high mortality risk, then I was learning from your presentation that we have to check the myocardium first in this case, and then to decide in accordance to the clinical.
Yes. So if the patients with moderate AS and myocardial fibrosis, do you think the AVR improve the patient's prognosis? I experienced, I experienced many patients after TAVI, but they have the heart failure. So I think the most important thing is that the evaluation of accurate severity of AS, maybe.
Okay, thank you so much.
Thank you very much.
Thank you for your brilliant lecture. And do we have the questions from our panelists? Professor Hung, do you have any question to Professor Chisato Izumi?
I think I don't have questions. I appreciate Dr. Chisato Izumi's wonderful speech and your mentoring. Thank you.
Thank you.
Thank you. Thank you very much. We wish you all the best. Thank you for your contribution.
Thank you.
So, Professor Hung, please invite the next presenter.
Okay, yes. For the next speaker, we're welcome and we are honored to invite Dr. Nguyen, currently the Associate Professor and the Vice Director of Department of Cardiology from Hanoi Medical University, and also the Vice Director and the Head of CCU in the Vietnam National Heart Institute from Vietnam. I think we definitely can learn and we can get a lot of information from his speech entitled "The Low Flow, Low Gradient Severe Aortic Stenosis in Heart Failure and Reduced Ejection Fraction, the decision by dobutamine stress echo, CT calcium score, or extra-aortic valve cardiac damage." Dr. Nguyen, please.
Dear Chairman, dear colleagues, ladies and gentlemen, first of all, I would like to thank the APSC to invite me to sharing and contribute this a very interesting forum. My topic is discussing about the low flow and low gradient severe aortic stenosis, and I might be echo quite a few slides from Professor Chisato Izumi, but we share the same vision about what we can do for our aortic stenosis patient. Here is my disclose. So basically, when we're talking about the aortic van stenosis, there are a few kinds of way of staging, and I just bring some slide to show the stage of the aortic van stenosis by ACC. They classified asymptomatics and also symptomatic. Yes, it become like a C1, C2, D1, D2, and D3. And my topic today is just focused for this group with severe aortic stenosis, and mine came from the C class or D class. According similar to the Professor Chisato, it is a slight recommendation from timing for AS intervention. Usually, you can see here that the question is come like patient asymptomatic or not, and also how severe the aortic stenosis is. And everything's also similar from the OSC. guideline last year, we also need to consider how severity of the aortic stenosis. However, this is only one thing to determine which way is the best treatment for the patient. Usually, we need to consider the comorbidity and also the factor to predict the poor TAVI outcome, because this one impact a lot for the outcome of the patient. And you can see here, everything here is chronic lung disease, advanced kidney disease, and also some cardiac condition like a poor EF and also the pulmonary hypertension. And this one is what we need to consider when we do the TAVI. And basically, for management individual van case from now on, usually we totally, I agree with the Professor Chisato in the previous presentation. We need to consider how the symptom contributes by the van disease or not. And also we need to consider another marker for the van heart disease, marker for the intervention, and also the risk marker for the patient as well. And after we combine the whole thing together by the heart team, we decided which strategy for the patient based on the patient design. So I think that this is very important to identify exactly how severity of the van disease and how we can connect the severity of the van with the symptom and also the damage on the cardiac myocardium or extracardiac. If we see the guideline, you can see here guideline from ACC, AHA, OSC, SDSC, Canadian Society. You can see very few areas. They have area of agreement and also disagreement, and also the gap in evidence. So basically, every people is likely to agree on the definition of severe aortic stenosis. But another way, they don't have agree on using the biomarker like BNP to use to identify and stratify the risk of the TAVI case. And also, we lack of the quite evidence for the case with the moderate AS, as we discussed in the last period. So basically, when you see the trend, you will see the current paradigm of the aortic valve replacement. Basically, we based on the severe symptomatic patient, and also if the patient is asymptomatic, we likely to consider the TAVI in very severe aortic stenosis. And based on a lot of things here, we can go a little bit into the early, into the asymptomatic phase when we have something already happened with the myocardial or for the case with the moderate AS, but already have an impaired LV function. So this is the trend and now. We think that every society have the agreement on the definition, but however, is not really. If you think carefully about the criteria for aortic stenosis, every society based on the aortic valve area, the mean gradient through the aortic valve, and also the Vmax velocities through the valve. However, it is important like the way how precise you can identify these parameters. And also for the case with the aortic stenosis, usually you need to identify another parameter on the echo to have some prognostic side. For example, like a very high gradient AV, rate of change AV Vmax, global glutinous strain, or increase LV max. So this is something like the other factor to contribute for you to identify the best treatment for the severe aortic stenosis. The prevalence of the low flows in aortic stenosis is quite significantly. Here, this is the case, a lot of study by echo or by the CAT. You can see here prevalence of the paradoxical low flow CVAS is around like 15 to 20%. And you can consider the similar for the low flow and low gradient CVAS with the reduced AF. Another important here is if we identify the low flow state by the echo and you measure in different sites, you can see here there is a lot of different way to to identify the low flow AS patient. So basically, the standardized protocol to identify the severe aortic stenosis is very important. If you put everything into one chart, you can see here the definition of the severe AS, ACC, AHA, OSC, STS are quite similar. But however, in the real life, you have some concordant and discordant. Basically, the severity of the aortic valve based on the area of the aortic valve. But however, another point is important to the mean gradient transaortic valve. You can see here, if at more than 40, it is a concordant and it is a severe aortic stenosis. But however, if we have something like a concordant, you need to identify which way is a severe aortic stenosis or it is a moderate aortic stenosis. Similar thing, if you jump back into the moderate group with the aortic valve from the 1 to 0.15 centimeters square, and also the moderate mean gradient like from 20 to 40, and there is quite a few cases actually can be reclassified into the severe aortic stenosis. So you should keep in mind that the concordant and the discordant between the anatomy and hemodynamics always happen, especially for the case with the low flow and low gradient. And this is a percentage, it is a discordant prevalent between the gradient and the area, between the anatomy and the hemodynamic, and especially in the patient with the low flow or with the patient with the radio AF, the main topic for my presentation, actually it's come like from 30 to 40% discordant. So that's why you need to have a multi-modality to identify the severity of AS, and also you need to have a very standardized protocol to like that. Another point is important is the progress of the aortic stenosis. You can see here, this is the progression of the valve through the ear, and in some cases can progress very significantly and fast. So that's why you need to have a quite regular follow-up. Based on that, you can see like if the cutoff valve is like 1 centimeter square, actually the gradient should be like a 32, and also the Vmax is 3.7. So compared to the diameter, the gradient like 40, and so the Vmax is 4 meters per second, then you can see there is some difference between the case, and that's why you need to think about another modality. So in this group with the low gradient, low AF, AS, it considers another method. It is sweat echo, and usually you use the dobutamine sweat echo, increasing the dose and to identify the LV flow reserve. And if the LV flow reserve have more than 20%, and then you can classify it as a true severe AS. But however, there is some group it is like undetermined or in the gray zone. And for example, like the K don't have enough flow reserve, and then you cannot classify which one is severe or not. Another way is important, like you can have a more aggressive approach to this group. It is a practical guideline from British Society of Echography, and usually they apply the dobutamine sweat echo for the case with the mean gradient from the 35 to 40. Basically, they they can consider the patient with the more than 35 millimeter mean gradients is already like a severe stenosis. And after that, using the dobu sweat echo, you try to project the arrow, and if the area office area valve is less than 1 centimeter square, you have a true severe aortic stenosis. But however, even in this case, you still have some case like indeterminate. You cannot classify which one is true or Percutaneous aortic stenosis. And for this point, you also consider like you lower the threshold, and you apply the same thing for the moderate gradient severe AS. And if the patient got a mean gradient is low and quite moderate, or the aortic valve is in the borderline area, you also think that you apply the dobutamine sweat echo to identify the case. Another point is important is aortic van calcification. So this one identified by the CT, but we can see the relationship, very good relationship within the calcification with the mean gradient and also the mean area. And also this one is go align with the gradient and also the aortic van area by echo through the time. So basically you can consider like AV calcification as another tool to identify severities. So this is a protocol here, as you can see here. There is some few things discordant between the two big society, but however, for the threshold, if the calcification is more than 2,000 in Agason unit in men and more than 1,200 in women, this is likely the severe aortic stenosis. And if this one threshold is higher, the more likely for the aortic severe stenosis. Another point is important, like if you do the more CT to identify the aortic van calcification, you also need to consider the non-calcified tissue. And it is the paper is quite recently talking to us that in women, the non-calcification tissue actually very important and can to predict the severity of the valve. So there is a few ways to identify, to combine the drug, the threat dobutamine echo with the multi-slide CT. You can do the multi-slide CT first or second after the dobutamine. And it is another example for evolving approach. You do the routine thoracic echo first, and after that you do the multi-slide CT. And if the patient got a likely of the CVAS, and then you can do the redo the TE, or you do the dobutamine threat echo to identify. So this one, if you do the multi-slide CT first, of course you use a higher threshold. If you do the dobutamine first and then you apply the low threshold for the aortic van calcification. Another thing is important to use that for some case, especially for the case low gradient, low flow, but preserve EF, and then you can thinking about using the thread echo with the vasodilator rather than dobutamine, because in some case the afterload contribute a lot for the gradient, and then in this situation sometimes you cannot increase the dobutamine dose very much. So the Mayo Clinic colleagues already testing and showing that if the case with the low gradient, low flow aortic stenosis with preserved AF, you can apply the need to proceed, and this one can also reclassify about 20% for the case with the flow reserve. And some author already thinking about apply the same protocol to the low gradient, low flow aortic stenosis, but with the reduced EF. So if we combine all data together, combine the data from the flow, from the valve, the anatomy, and also the state, you can put everything into the one paragraph to stratify the severe aortic stenosis. But however, when we look back into the data, if we put patient for the TAVI, you can see here the TAVI in the low flow, low gradient aortic stenosis, and even for the LV function is less than 30%. This is a sub-study from the TOPAZ TAVI registry. You can see that this one showing the same outcome for the patient with the AF moderate reduced. And in this situation, you can see that the flow reserve in dobutamine thread echo did not influence for the outcome. So basically that you try to use a dobutamine thread echo to identify the more case for TAVI, but actually is not, the flow reserve did not impact a lot for the outcome. So for the severe case, even for the low gradient or the low flow, you should think about do the TAVI, and the outcome is already increased through the time. Another slide, Professor Chisato already mentioned before, you try to staging by the external cardiac damage, but however, this one is
showing that for the TAVI indication, somehow every case with the CVAS, you still put a TAVI in. And this extra cardiac damage might be influenced for the mortality rather than the TAVI itself. Another situation when the aortic stenosis is not work alone and combined with another valve, and maybe other speaker already mentioned for the following presentation. But however, in this situation is quite important, and you should think about all the anatomy and also the hemodynamic to identify the best strategy for the patient. Everything we discuss here is discuss the way to identify the most severity case for the AS. But actually, we just touching the tip of the iceberg. It is only the severity of the valve. We don't mention a lot for the other things like ischemia, like myocardial thrombosis, and also the dysfunction of the LV for the long term. So this one is, as a previous speaker mentioned, we already have quite a lot of tool imaging to the LV assessing, and also to give us the prognostic information. Here, sorry for the small table, but usually summarize all of the technique now to identify the valvular damage and also the myocardial consequence due to the aortic stenosis. And this one can help us to identify the case for the TAVI, even for the case with the low gradient, low flow aortic stenosis. And also, you can see here that we have a new imaging parameter for AS diagnosis and prognostic. For example, like in echo, we can have something like a flow rate to assessment the aortic stenosis, and also can reclassify about 10% of the case. Another tool here is based on the multiplicity. When you do the multiplicity for the AV classification, you also can identify the ECV is a marker for the myocardial fibrosis, and this one can help you to identify further the case for the future, and also for the case can benefit from the TAVI procedure. However, we come into the last part of my presentation. It is only the parameter based on the image. But however, the extra cardiac parameter is very important. So we need to think about when the TAVIs get the poor outcome. So this is something like based on the very high-risk patient group, and also for the Nguyen database registry. You can see here, something here is impact for the long-term outcome. And it is something like a atrial fibrillation, and another parameters not for the cardiac. It is like a CKD, it is a CDPD, and this one is the data came from Japan colleagues, the Ocean TAVI registry, showing that the predictor for the poor symptomatic improvement is AF COPD, CKD, and moderate CVMR. So basically, that everything I show you here mentioned that the severity of the aortic van stenosis is only to help you to identify the timing for the TAVI, but for the long-term outcome is not only based on the valve itself, it also based on the other factor, especially for the aging population like AF COPD or CKD. And of course, you need to think about the risk factor for the full utility in the TAVI, and it is this chart is summarized, can help you. We can consider the cardiac condition, we have to consider like extra cardiac condition, and also the few things like a frailty to help you to identify the which patient is the best or can benefit from the TAVI. And for example, like a lot of cases, you think that the case is too severe for the TAVI, like the LV dysfunction, diffuse fibrosis, combined with the secondary mitral stenosis or LV dysfunction. But actually, these comorbidities can be reserved by the TAVI. So think it again and think about this again. And also, if you really want to refute the TAVI, you should consider the extra cardiac condition rather than cardiac condition. Dear colleagues, ladies and gentlemen, I would like to conclude that the low flow, low gradient severe aortic stenosis with or without reduced EF is a special group with the many challenging is diagnostic and management. Pharmacologicals, not only dobutamine, also the vasodilator as well. And multiplicity can reclassify about 20% more. more the case, but not for every equivocal case. So that's why we need to do more study, more data, more innovation and algorithm to combine the multi-modality to identify the perfect case for that. And I think that extra van and extra cardiac damage has strongly influenced on the decision-making and outcome post-TAVI. And especially for the extra cardiac damage is very important, more than the severity of the aortic valve itself. So that's why this is something like I want to echo Professor Chisato, Izumi, and also our moderator, that we can shift the compulsory TAVI program into the early phase of the aortic stenosis. And this is my presentation, and thank you very much for your attention.
Yeah, wonderful. I think I would like to say, I think Professor Quang's wonderful speech, which highlight the critical issue about the low gradient and low flow aortic valve stenosis in patients with preserved or even with reduced ejection fraction. I think the speech is highly valuable and pointed out several critical points in our daily practice. So we welcome the questions from our panelists and all participants.
So I have a question about the abdominal stress echo. Okay.
Yes.
You make a presentation and you perform a CT first, and after that you choose the pharmacological stress indication. So I think prevalence of abdominal stress echo or pharmacological stress echo is very depends on the institutions. So how many % of patients with low flow, low gradient severe AS and reduced ejection fraction do you perform abdominal stress echo in your institution or in your country?
Thank you, Professor Chisato, for your question. So in the reality, is depend on the protocol, and also the for multi-slicity, even we can put a quite high threshold. It also depend on the experience of the technician and to identify the data. So basically, I just mentioned that we have another way to do the multi-slicity before the lobutamine stress echo. Because it is somehow like a discussion and to bring to discuss. In the reality is we just follow the normal one. We do the double stress echo first, and then if the case is unequivocal, we transfer the patient for the multi-slicity. However, I frankly have to say that our young doctor is think a little bit different because they think that they also need the multi-slicity to do planning the TAVI if they would. So that's why they said after they do the screening with the normal echo, even the patient with the low flow, low gradient AS, they send directly to the multi-slicity to do not only for the aortic van classification and also to do the full multi-slicity evaluation for the TAVI. So after that, they have enough information to decide it. So I think this one is also another good approach and depend on the availability of the echo, of the technician, of the device. Because for the dobutamine stress echo, somehow some doctors are still concerned about the complication after you give the inotrope. So that's why multi-slicity first may be a good option in some new center for the TAVI.
Thank you.
Yes, and I agree with the Dr. Quang's opinion, and we welcome. Maybe Professor Mungunchimeg would like to have some comment or questions.
Yeah, I have just one pragmatic question. In the clinical scenario, how frequently you face a severe aortic stenotic patient with atrial fibrillation, which is also kind of resembling a low flow, low gradient aortic stenosis? And what is your strategy in this case for timing and estimation of aortic stenosis severity?
Yeah, thank you, Professor Mungunchimeg, for the very important question. I think that in the reality, we low gradient, low flow aortic stenosis can up to 30%. And about 1/3 of that, meaning that about maybe up to 10% patient can have AF. The issue here is, in reality, in Vietnam and maybe in Mongolia and also ASEAN also the same, we have some part of the degenerative and some part of the rheumatic heart fever. If the patient have the rheumatic heart fever, they easily to have AF with the mitral stenosis or mitral regurgitation. For the degenerative one, in old patient, AF is really the bad predictors. If the patient got a severe AF and then, if the patient got a very severe aortic stenosis and then got AF, the timing for mortality is might be like 1 to 3 months. So that's why we need to go a little bit fast. And if the patient got a significant severity of the valve, or by the gradient through the valve is high, then we need to think immediately about the TAVI or SAVI, because it is the best way to curve the patient. We cannot wait for the patient with the AF, I think.
Okay, thank you. And do you often use projected aortic valve area and dobutamine testing? Will you recommend it for the routine use?
Yeah, I frankly have to say that in our center, we not routinely use that. The most important thing here is we need to have a standardized protocol for that. When do the review literature for this presentation, I think that some recommendation from the British Society of Echocardiography is very good. And also they mentioned the standardized view and standardized protocol to measure those things. And I think it's useful for us to identify the severity of the valve. Somehow, because when the case with the severe calcification, you can also think about do the aortic valve calcification qualification by the echo, not only by the multi-slicity. It is another way to combine the two together.
Okay, thank you. Thank you so much for your brilliant lecture.
Welcome.
I have no other questions. Do we have no? Okay, then due to the time constraint, we go for the next presenter, who is my colleague, Dr. Nyamsuren Sainbayar. He's a cardiovascular surgeon, cardiovascular surgery department, 3rd Central Hospital in Mongolia. He will speak on critical timing and the candidates of surgical treatment for chronic severe aortic regurgitation, decision by aortic regurgitation severity alone or concomitant aortic root damage. Welcome, Dr. Nyamsuren.
Hello, good afternoon, everyone. Thank you very much for giving me opportunity to participate in this wonderful conference. Today we will discuss about this chronic severe AR as a decision by the AR severity alone and concomitant aortic root damage. Aortic regurgitation, most common causes is primary and secondary. Primary causes is congenital malformation and leaflet prolapse, leaflet perforation, rheumatic heart disease, connective tissue disorders. Secondary is usually natural hypertension, idiopathic, and syphilis, other connective tissue disorders. It's a common etiologies as aortic valve lesion is under analysis, so dilatation, abscess, calcification of the leaflets, distension, tear, vegetation, commission is a rupture, fusion, calcification, Aorta is dilatation, aneurysm, dissections. The pathophysiological aortic regurgitation is a chronic AR is generally evolves and slowly imposes a combined volume and pressure overload. This hybrid hemodynamic is a remodeling of the left ventricle dilatation and eccentric hypertrophy. And clinical practice we use also as functional classification is a Carpenter's classification. It's divided two types of the group. Type 1 is aortic valve regurgitation, normal leaflet motion. Type 2 is aortic valve regurgitation, is a leaflet prolapse. Type 3 is a AR, restricted leaflet motion, and during the opening in the closure phase. Type 3B is a AR, restricted leaflet motion, and it's just only closure phase. This is a dysfunction and corresponding lesions. As a grading as AR severity by the echocardiography. A single echocardiography measurement cannot prove the AR severity alone. Therefore, we need to multiple parameters for the assessment of the AR. This is a dilatation of the aortic root and descending aorta. CT scan and echocardiography is a normal range. Pathophysiological triad, etiology is the cause of the disease. Lesion is a result from the disease. Dysfunction is a result from the lesions. So surgeons, we should treat and the lesion dysfunction and the lesions. According to ACC guideline in 2020, at the timing of the intubation, is if patient is severe AR patient is symptomatic, is surgery candidate is a class 1. But asymptomatic patient, if left ventricular ejection fraction less than 55%, as a surgery indicated class 1. If asymptomatic severe AR or undergoing an aortic cardiac surgery is a candidate surgery by the class 1. And the class 2 indications is if left ventricular ejection fraction is more than 55% and end systolic dimension more than 50 mm, and end systolic dimension index in 25 mm square is a class 2 candidate, class 2A candidate. Also, it's a progressive increasing in ejection fraction is less than 55%. Increased left ventricular end diastolic dimension, it's more than 65 mm. It's a patient have low risk of surgery, we should indicate the surgery class 2B. If a patient, a moderate AR patient who is undergoing aortic cardiac surgery, aortic surgery candidate AVR is a class 2A. This is ESC guideline 2021 as a management of the aortic regurgitation. Is a patient have a significant aortic enlargement, we should surgery consider. And if the patient no aortic enlargement and severe AR is symptomatic, a surgery indicated. Asymptomatic cases, we call it the 50-50 rule. Is a less the ejection fraction is less than 50% and end systolic dimension more than 50 mm. It's this patient have also surgery candidate. This is a comparing of the class 1 recommendations. I just mentioned before. It's all the 4 cases. It's a symptomatic AR case, regardless of LV systolic function, class 1. Asymptomatic case is LV rejection fraction is less than 50%. Both guideline also class 1. And asymptomatic severe AR case undergoing aortic cardiac surgery, both guideline also class 1. This study assess outcome and the risk factor in the outcome, the risk factor aortic valve replacement. Aortic valve this patient severe markedly reduced ventricular function as a comparing in the order moderate and the severe preserved LV function groups. This low ejection fraction low ejection fraction is presumably in the poor prognosis after this surgery. But in this case, what in this study shows to us is a patient markedly reduced LV function group, and the post-operative outcomes and the survival is similar to the moderate and the LV and preserved group. Another study, that the timing of the timing of our repair replacement patients is severe error is still controversial. They studied an effect of the left ventricle function, survival, recovery of the left ventricle performance, and after the dimension of the after correction of chronic severe AR. This type of group is the red line. Red line group is ejection pre-op EF is more than 60%. Its a survival rate is much better than in a reduced group. And this diagram shows is a pre-operative EF is a blue line, is a red is a post-operative EF. Post-operative, there might be marked decrease in the lateral EF post-operatively, but in the long term, post-operative slowly increases in after the pre-operative eventually. This is comparing of the recommendation class 2. And the symptomatic patient as a severe AR, the function is more than left ventricle ejection fraction more than 50% as class 2 in the both guidelines. If LV dilatation and systolic dimension is more than 50, the both guidelines also recommend in the class 2B. And systolic dimension is more than the 60 asymptomatic patients, severe AR, and systolic dimension more than 65 mm. It's with low surgical risk, and the AAC guidelines is recommended surgery class 2B. Also, aortic valve repair considered. Aortic valve repair considered in selected patients experience center AAC guidelines class 2B. Now we talk about the timing and duration of the bicuspid aortic valve. And then bicuspid aortic valve cases as aortic sinus is ascending aortic sinus or ascending aortic diameter is more than 55 centimeter is a surgery replace the aortic root and ascending aorta as class 1. Aortic sizes is 5.5 to 5.5 centimeter. Any risk factor of the dissection, we should replace the aortic root and sinus. And indications, if patient have a primary surgical aortic valve indication, and whose aortic sinus diameter is more than 4.5 centimeter, also replace the aortic sinus ascending aorta. Lastly, the aortic sinus ascending aortic diameter is 5.5 to 5.5 centimeter. Without any dissection, replace the aortic root and ascending aorta. Also, is while sparing the surgical treatment options, also considering the while sparing surgery may be considered at a comprehensive valve center, class 2B. This is according to EAC guidelines. Aortic root and tubular ascending aortic aneurysm. While sparing root replacement is recommended in young patient with root dilatation and performed experience center EAC as a class 1B. Ascending aortic surgery is a patient with Marfan syndrome patient whose aortic root disease is maximal aortic diameter more than 50 mm is a class 1C. As the timing of the ascending aortic surgery, it should be considered for aortic disease is maximal diameter 55 millimeter, more than 55 millimeter all case, we should be considered the surgery. If a Marfan case is maximal aortic dimension is 45 mm, patient have any additional risk factor, class 2A, we recommend surgery class 2A. More than a bicuspid valve case, if a maximal aortic dimension is more than 50 mm, is a class 2A, class 2AC, class 2A. Now this study is a reconstruction of the recurrent bicuspid valve It has been performed a 10 years study and 10 years follow-up. This is a bicuspid valve surgical repair of the bicuspid valve. It's a follow-up curve. It's a reparation. It's a freedom from the reparation curve. We see that it's a commissural orientation of the bicuspid. Its orientation is more than 160 degree. This group is much better result than the reduced orientation, commissural orientations. This is a freedom from the reparation as a preoperatively an aortic and ventricular dimension. Comparing, it depends on the preoperative aortic outer ventricular dimension is less than 29 mm. Is much better than result in dilated groups. This is a survival and the reparation patterns of the 20 years experience in aortic valve sparing root replacement, tricuspid and bicuspid valves. This is a freedom from the sorry. This table shows to us this case is a bicuspid valve case, and there's a Marfan case, and this is a reimplantation group. This is remodeling group. It's a severity of the AR. Ascending aortic dimension. Ascending aortic dimension is a remodeling group. Is ascending aortic dimension is larger than a reimplantation group. We see that annulus of diameter is similar to those. This is Kaplan-Meier survival curve with the reimplantation and remodeling technique. We see that this aortic valve sparing replacement survival is near of the normal survival. It's a very nice result, but it's the last decade of the second decade of the postoperatively. It's slowly decreasing. It's an instance of the reparation rate. As a red line is remodeling, blue line is reimplanting. And second decade after the operation, this patient with bicuspid aortic valve case is increase the reparation, especially in the bicuspid aortic valve patients. This is about sparing in the root replacement compared with the composite valve graft procedure. This aortic root disease patient, they treated three types of the operations. And the first is aortic valve sparing operation. Second one is mechanical composite valve graft, and the third one is bioprosthetic composite valve graft. They also analyzed in the major adverse valve-related events. This group, we see that this green line aortic valve sparing groups is much better result than other groups in the major adverse related events. This is a prevalence of the reparation. Prevalence of the reparation of the timing. The assessment of the two groups. We see that the reparation rate is much increase in bioprosthesis as a composite valve group, and valve sparing and mechanical valve composite valve group is reparation is much less. This is prevalence of mortality from the cardiac mortality from cardiac causes. And aortic valve sparing group is much better result of the other groups. So it's okay. And this is a Marfan syndrome patients is ascending aortic surgery. Their observational study was consecutive with 499 Marfan syndrome patient. This Marfan syndrome patient is AR, is aortic root height indicus, aortic root sinuses. There's divided two groups. First group is emergency surgery group. Second is a prophylactic surgery group. And we can see that emergency surgery group is a emergency surgery group is aortic root, and the aortic root sinus is a 4.5 centimeter and 4.4. But it's a prophylactic surgery, so it's much bigger, because it means it's emergency case aortic root size smaller than cut off the dimension of the recommendation of the guidelines. This study is comparing in the Asian and European population, European people. It's inter-ethnic differences, valvular morphology, and valvular dysfunction, aortopathy between Asian and European patients with bicuspid aortic valves. And this is the first time of the large multicenter registry study in Asian registry study in Asians with the bicuspid aortic valve showed more frequently type 1 with fusion in the right end, the non-coronary cast, but then have a larger aortic dimension in the Europeans. This table we see this is an Asian group, is body surface area, and type 1 is a much type 1 is a right and non-coronary fusion is much cases Asian group is the Asian group than Europeans. Annular dimension indexed by the body size is aortic Asians is much bigger. It means it's a dimension, aortic dimension comparing those body size is an indexed dimension is much larger Asians in the larger than the Europeans. Indexed diameter of the aortic annulus and the sinotubular junction descending aortic is very significantly larger in the Asian group compared with the European. Thank you very much for your attention.
Thank you, Dr. Nyamsuren.
Thank you very much.
Okay, do we have any questions from panelists, from audience to Dr. Nyamsuren?
So I think that Sainbayar for the wonderful share, and I have a question about the application of novel or advanced imaging. Just as mentioned, we mentioned about in the clinical condition of aortic valve stenosis, will they play a role in the timing of aortic valve regurgitation from your experience or from your review?
Sorry. Excuse me. Can you repeat again?
Is the question is clear?
No, I'm sorry. Can
Okay.
you repeat the questions? Sorry.
Okay. What I'm saying is that just in the clinical condition of aortic valve stenosis, there would be multiple novel imaging techniques or some clinical predictors in the accurate timing of aortic valve replacement. And will they play a role also in the clinical condition of aortic valve regurgitation? Any normal imaging technique for the prognosis implication of accurate timing of surgery? Yes,
Great.
thanks.
Good. Thank you. It's an aortic valve regurgitation cases. It's the first line in the transthoracic echo. Diagnosis of transthoracic echo. If patient have any aortic aortic root disease, any aortic root dimension is a larger enlargement, we should check the CT scan. Also CT scan and magnetic resonance tomography. We analyzed how about the aortic root is annulus and then that's vasa vacinus and then ascending aorta. There is any. We realized what is the reason of the valve regurgitation, especially in the bicuspid aortic valve cases and root disease. First line is echo, first line is echo, also CT scan.
Okay. We are at 1:20. So if you don't have a questions, maybe we will shift to the last presenter, Professor Hang.
Yes, now we are moving to the next session, the final speaker from Professor Ming-Tai Lin. Currently, Ming-Tai Lin, Professor Lin is the Deputy Chair of the Department of Pediatrics in National Taiwan University Hospital, currently the largest and most famous tertiary medical center in Taiwan. And Professor Lin has wonderful experience and has a lot of cases in his clinical practice regarding the pulmonary valve replacement and the surgery. Now he's going to share with us the critical timing and the candidate for pulmonary valve replacement in severe pulmonary regurgitation following congenital heart disease surgery, and the decision by means of PR severity or right ventricular overloading. Professor Lin, please.
Thank you, Professor Hong, and thank you, Chairman. Let me share my screen first. Can all of you see my slide clearly?
Yes.
Thank you. Good afternoon, ladies and gentlemen. This is Dr. Ming-Tai Lin from National Taiwan University Children's Hospital. First, I would like to thank the organization committee of APSC to invite me to deliver this talk. Today, my topic is timing and the candidates for the PVR in the patients with severe PR following congenital heart surgery. Here is my outline today, including impact of PR and the patients entering into their adulthood, and also current guidelines and their rationales, and the reappraisal of the current guidelines. The last is future direction and the summary. As you know, the patients with anomalies of RVOT accounts around 20% of all CHD patients. And among them, most are patients with tetralogy of Fallot. So I would like to narrow the scope to the patients with repaired the tetralogy of Fallot. About tetralogy of Fallot, which included 4 major lesions, including VSD, PS, overriding of the aorta, and the right ventricular hypertrophy. Currently, there are around 120 fresh cases of tetralogy of Fallot in Taiwan each year. In the developed countries, the success rate of TOF total repair is quite high. The mortality rate is less than 1%. Therefore, the percentage of adult patient with a history of tetralogy of Fallot is more than the pediatric group. However, the survival of such patient will decrease dramatically after their age of 25 years. The occurrence of arrhythmia in such patients had a similar trend. The occurrence of arrhythmia, the incidence of arrhythmia in the patients with repaired tetralogy of Fallot will increase up to 10% when such patients become older than 40 years old. So such mortality and the morbidity are thought related to patch associated with chronic PR, which will cause RV dilatation and the heart failure. And in the patients with repaired tetralogy valve, more factors contributed to such RV dilatation, including the residual septal defect, the ventricular dysfunction, the ventricular scarring, peripheral pulmonary stenosis, arrhythmia, and the aortic dilatation. Let's look at the 2018 AHA guideline, which suggested those with symptoms or satisfy RV volumetric criteria were indicated to have a pulmonary valve replacement. In the ESC guideline 2020 version, which also had a similar recommendation for those with severe PR together with the symptom, or together with RV volumetric parameters. Why these two guidelines didn't use pulmonary regurgitation only as indication in the patients with repaired tetralogy valve? I think there are two major rationales. The first is previous studies, and the second is pathophysiology. Since 2000, tons of studies work on the risk factor analysis of patients with repaired tetralogy valve, and found that pulmonary regurgitation together with RV dilatation or LV dysfunction are important prognostic factors in this patient group. The other rationale is based on the observation from patients with isolated pulmonary regurgitation. 40 years ago, Dr. Shimazaki, Blackstone, and Dr. Kirkley, they observed the patients with isolated pulmonary regurgitation and found after 40 years of age, the occurrence of symptoms will increase dramatically. However, in the patient with repaired tetralogy valve, they will grow up, and their RV hypertrophy will decrease. Their central pulmonary arteries will grow gradually, and the pulmonary annulus will enlarge gradually, and also their heart rate will decrease gradually. Therefore, the severity of pulmonary regurgitation may change. In the start of the 21st century, Dr. Cooknet's team set up a SUMAI model, which demonstrated beautiful findings. That is, they deployed a stent at the level of pulmonary annulus and found the pulmonary regurgitation percentage increased with age, and their RV compliance, pulse pressure of main pulmonary artery, and the duration of diastole will increase. Will increase gradually. So together the above, you can imply that at the late phase of tetralogy valve repair, the RV will become more compliant, less hypertrophic, or even dilated. The pulmonary artery will become more dilated, more prominent, the pulse pressure of main pulmonary artery will become more widened. Together with the above effects, there will be a virtuous cycle for the patients with repaired tetralogy valve. The RV the pulmonary regurgitation will cause RV dilatation, and when the patient grow up, their RV compliance will increase. which will result more pulmonary regurgitation, and there will be a vicious cycle. Let's do a comparison between AHA and the ESC guideline. You can see both guidelines focus on the PR severity, RB volumetric parameters, and the AHA guideline also enroll the patients with RB outflow tract obstruction, and also those with sustained arrhythmia. The guidelines recommends such patients that are indicated for pulmonary valve replacement. So let's do the appraisal for the current guideline. Did the PVR really improve major outcomes? Let's let's look at the Indicator Registry, which is an international multi-center registry of patients with repaired tetralogy of Fallot from 4 medical centers. The registry started since 2011, which enrolled patients with repaired tetralogy of Fallot who had cardiac MRI between 1997 and 2010, and also who had 12-lead EKG within 1 year from cardiac MRI, and also had more than 1 year follow-up after MRI. At 2018, the case number enrolled increased up to 977. They compare all-cause mortality, aborted sudden death, aborted sudden cardiac death, sustained BT between those with PVR and those without. And they found no significant difference of major event between these two subgroups. You may criticize both subgroups had different characteristics and underlying parameters. Yes, they also take this difference into consideration and conducted propensity score adjusted comparison. They pick up one by one matched subgroups, which is composed of 256 patients in each subgroup. And again, the PVR didn't benefit more to the patients. And they also found the RV ejection fraction is one of the independent risk factors for the outcome, the major outcomes of the patients with repaired tetralogy of Fallot. Is such a phenomenon due to non-adherence to the guidelines? The study group, they found for those meet guideline criteria, the PVR didn't benefit more. But for those didn't meet guideline criteria, if they had the PVR, the PVR may harm the patients. So they concluded that although following guideline didn't guarantee benefits after PVR, higher event rate might happen if you didn't take guideline into consideration. Next issue is, did the Transcasita approach change the results? You might already know there are balloon expandable and self-expandable pulmonary valve grafts. Let's look at the Melody valve first. The Melody valve group, in this February, had reported their 10-year follow-up results The case number is 171. They found the RV and diastolic volume index did decrease significantly. And the percentage of PR also decreased and improved. But the ejection fraction of right ventricle and the left ventricle didn't improve significantly. And the 5-year mortality is around 4%, which is similar to Indicator Registry. How about the native RVOT? In Taiwan, limited resources of homographs. Therefore, more than 90% of RVOT are native or glutaraldehyde treated pericardium. Here is the timeline of percutaneous PVI in our hospital. My mentor, Professor Joko Wang, started PPVI since 2015. And since 2018, we started PPVI on the native RVOT. And at the end of 2019, we had Pusaba. The table shows you the criteria for PPVI in a hospital, including symptom, age, body weight, the PR percentage, and RV function, and the EKG changes. Here I show you an example. Who is a 13-year-old girl who had the venous P-valve implantation. You can see we advanced the whole assembly into the LPA. And from the left lower panel, you can see we pull back the outer sheath gradually, and let the stent graft expand spontaneously. And finally, we repeated the MPA angio, which showed very good results. The other case is Pusaba. She is a 31-year-old female who had repaired tetralogy fallot, moderate PR, dilated RVOT, and the LPA stenosis status post LPA stenting. For this case, we pick up the Pusaba for PPVI. First, you can appreciate the MPA angio showed the moderate to severe pulmonary regurgitation. And then we advance the whole assembly to the RPA. And again, we pull back the outer sheath gradually, like the left panel show you, and the final angio show a very excellent result. How about the result of our group? So far, we had performed PPVI on the 54 patients with the RVOT anomalies. The table shows you the detailed results. The results are good. Only one patient had the embolization of the valve graft, who had the surgical intervention thereafter. About the midterm results, you can appreciate all of them experienced reduction of RV and diastolic volume index, and most of them had the functional improvement. However, for the right ventricular ejection fraction, only half of them had improvement of RVEF during the follow-up. So how come we follow up the guideline, but we only achieve reverse modeling of the right ventricle rather than better survival or less major events? Did we miss anything else? I guess yes, including history of ventricular arrhythmia, LV function, biomarkers, and the RVOT geometry. If you search for previous study, several studies demonstrated history of ventricular arrhythmia are one of the important prognostic factors in the patients with repaired tetralogy follow. And also my colleague, the Dr. Sen and the Dr. Chen, they found outflow tract geometries are associated with adverse outcome indicators in this patient group. They found pyramid geometry is associated with adverse outcome indicators. And we also we may also neglect LV function over interventricular interaction and the biomarkers. We ever studied prognostic factors associated with cardiac pulmonary function improvement in the patients who had venous P-valve implantation. And we found levels of NT-proBNP and LV and diastolic pressure are both good indicators. For those patients with BNP levels less than 70 picogram per deciliter and the LV and diastolic pressure less than 11 millimeter mercury are significant, have had a significantly significantly more chance to have cardiac pulmonary function improvement. So let's go back to the question. Critical timing and the candidates for PVR in severe PR following CHD surgery. Fundamentally, you need to check the severity of pulmonary regurgitation and the RV volume changes. And also, in the future, you need to take biomarkers and the RVOT geometry, LV function, and the history of arrhythmia into consideration. Then you may identify the suitable subgroups who can really benefit from PVR. I believe this will be a very important issue. Thank you for your attention and welcome for your comments and questions.
Thank you for your brilliant lecture. Thank you very much.
You're welcome.
And do we have a question from, so my co-chair, Dr. Hang, left as he apologized. So do we have a question from our panelist to Professor?
I have a question about the cutoff value of RV volume. Do you think the current guideline cutoff value of RV volume is appropriate? And in intervention era, do you think the cutoff value will change or not?
Actually, I think this is a good question. Some studies from the US or Canada, they ever evaluate if they use more stringent criteria like 150 or 140 cc per square meter and analyze the indicator registry, but the results still the same. So the issue may be not volume only, maybe like I mentioned earlier, the ventricular scarring or some electric physiology changes or some factors still unknown contribute the prognosis of this patient group.
Thank you.
Thank you. That means we should not look after the length of QRS.
Yeah, although these two guidelines didn't mention QRS duration, but actually, practically, for those QRS duration longer than 160 milliseconds, which will be one of the indicators for the patient, for this patient group. In the ESC guideline, only mentioned for those QRS duration more than 180 milliseconds are high-risk group for ventricular arrhythmia. So far, many studies demonstrated the importance of QRS duration. But if you base on this criteria and then go ahead and do PVR, the real benefit is still uncertain.
Okay, thank you very much. I guess, what I have learned, we have to check out the QRS, we have to check about after the cutoff value of and the diastolic RV dimension and systolic RV dimension, right? But in a real life, it may happen. It's just coming into my mind that if all the indicators are discordant to each other, what will be the strongest factor to
Yeah, I know. I totally understand such a situation because that did happen in our clinical scenario. For those patients who satisfied each criteria, there will be no doubt we send the patient to a surgical PVR or PPVI. But if patient had one or two criteria eligible for the intervention, so far my team depend on the group discussion. So far we don't have we still don't know which criteria we will have a stronger priority. Maybe there will be a scoring system in the future, I guess.
Okay. Okay, thank you very much for your brilliant lectures. And as the time is 1:48, and we are about to close, and Professor Chung-Lieh, do you have a word about?
No, I could only thank you for every presenter and also chairperson to lead the whole section. This section really needs a new rethinking for every one of us. We used to only think about a valve. Actually, we know that extra valve, there will be a lot of cardiac damage. We really think a lot from this section. Thank you for all the contribution of the chairpersons and also the speakers.
Okay, thank you very much for all presenters for fantastic lectures, and thank you all for your great contribution to the successful webinar of APSC's Cloud Webinar. And I hope to see you soon in the future. Thank you.
Thank you.
Thank you all.
Thank you very much.
Bye.
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 Thank you. Thank you all.